People talk about the core symptoms of dementia with Lewy bodies, and there are three of these. The first is the presence of visual hallucinations. In other words, people see three-dimensional, colourful, vivid, real-looking images, usually of people, sometimes of animate objects. The second core feature of dementia with Lewy bodies is fluctuation, by which we mean that any of the symptoms can vary quite markedly from one occasion to the next, sometimes even from 1 minute to the next. Fluctuation can affect things such as orientation, knowing what day and date and time and place a person's in. So sometimes a person might be very accurate about those issues, but then later on might be quite confused and need a lot of reassurance and explanation. The third of the core features of dementia with Lewy bodies is Parkinsonism. I think most people are familiar with Parkinson's disease, which causes tremor or shakiness, slowness, particularly in walking, and also stiffness of the limbs. In dementia with Lewy bodies, we see some of those features of Parkinsonism in about 3/4 of cases, and it can be the most disabling symptom. The core features of dementia with Lewy bodies are very useful to know about, because if they're present, especially if two or more are present, then the patient is very likely to have dementia with Lewy bodies. The limitation is that many patients with dementia with Lewy bodies don't have many or even don't have any of the core features. In order to overcome this, we've made an additional list of what we call suggestive features. The suggestive features of dementia with Lewy bodies are three. The first suggestive feature is sensitive to neuroleptic medications. Neuroleptic medications are essentially tranquilizers that are commonly given to people with dementia and with a wide range of conditions to calm them down. Research has shown us that neuroleptics, which are major tranquilizing drugs, are particularly dangerous for people with dementia with Lewy bodies. If they're given them, then there's a high likelihood, 50% or more, that people will have very severe adverse reactions in which they become much more Parkinsonian, they become stiff, they can't swallow, they can't eat, they can't move about. And because a lot of these are older people, they then very quickly develop the complications of immobility. And in fact, the death rate is 2 or 3 times increased following taking these kind of drugs compared with if they weren't given. It's of major importance that people understand that neuroleptics should not be given to people with dementia with Lewy bodies unless under specialised supervision and in conditions where other drug treatments have failed, then occasionally it might be necessary. The second of the suggestive features of dementia with Lewy bodies is a condition called REM sleep behaviour disorder. REM stands for rapid eye movement. I think most people know that during the night's sleep they have periods in which they dream, and in those periods the body becomes paralysed so that essentially they don't act out their dreams, they don't move around and wave their limbs about and shout. In REM sleep behaviour disorder, the body doesn't become paralysed and patients do wave their arms about, shout, and often injure the person who might be sharing the bed with them. REM sleep behaviour disorder is commonly found in the 10 or 20 years before somebody presents with other symptoms of dementia with Lewy bodies. So it's a very useful signpost or early indicator. The third of the suggestive features for dementia with Lewy bodies is the result of a particular type of brain imaging investigation. We've realised that a substantial number of patients don't have the typical clinical picture, and therefore we're going to have to resort to some kind of biological test to make the diagnosis. The best biological test which we have currently is brain imaging, in particular a type of brain imaging where we measure what's called the dopamine transporter, which is a neurotransmitter in the brain, which is reduced in dementia with Lewy bodies, but which is normal in other kinds of dementia, like Alzheimer's disease, and which is also normal in healthy elderly people. You can see, if you look at these scans, that the scan from a person with Alzheimer's disease is very obviously similar to the normal control, whereas this image, which is from somebody with dementia with Lewy bodies, is very obviously abnormal. The dopamine transporter imaging test is able to accurately diagnose patients at about a level of 85 to 90%, which is really much better than most clinicians can do. In order to improve the practice in this area, we need to diagnose dementia with Lewy bodies more often, particularly in the cases that don't look absolutely typical. The way that we can do this is for doctors to have a higher index of suspicion and carry out appropriate investigations in people who have a hint of dementia with Lewy bodies and whom they think, yes, this would be a possibility of a diagnosis. So, for example, a person with early dementia who's experiencing some mild visual hallucinations should probably be sent fairly quickly to have appropriate brain imaging, such as a dopamine transporter scan, which would really increase the level of certainty of diagnosis quite substantially. Dementia with Lewy bodies is essentially a specialist diagnosis, as is the diagnosis of any dementia subtype. The greatest asset that a doctor has in making a diagnosis of dementia with Lewy bodies is really clinical experience and having seen the disorder before. It's a process of pattern recognition. But having said that, there are certain tests which can be particularly helpful. For example, simple bedside tests like clock drawing can be very useful. There are scales that have been devised recently for measuring symptoms like cognitive fluctuation. These scales involve asking a relative a short number of questions about the person's performance from one part of the day to another, or about the person's sleep pattern. Some tests which are routinely carried out during the assessment of a person with dementia can be particularly informative if the doctor knows how to use the test. For example, most people with dementia get a CT brain scan, which is done usually to exclude strokes, space-occupying lesions, or other abnormalities inside the skull. In dementia with Lewy bodies, the CT scan will often show preservation of the hippocampus and medial temporal lobes, which are atrophied or shrunken in Alzheimer's disease. So even routinely done tests have some diagnostic value if used properly. The diagnosis of dementia with Lewy bodies is of itself quite traumatic. Usually the person receiving the diagnosis and their family hasn't heard of this condition before, and there's a considerable amount of education, explanation that has to be given, more than perhaps would have to be given with something like Alzheimer's disease, which most people will have heard of prior to them going to the hospital. The next stage in managing dementia with Lewy bodies is identifying exactly which problems are significant to the person suffering and also to the family. So, for example, a person may have hallucinations which are troublesome, but not as troublesome as the fact that they have a severe sleep disturbance. And so the treatment priority in that case will be to treat the sleep disturbance first. We do, of course, now have the anti-Alzheimer's disease drugs such as donepezil, rivastigmine and galantamine, which have been shown in clinical trials to be more effective in dementia with Lewy bodies than they are in Alzheimer's disease, for which they were developed. One of the most important things to understand about dementia with Lewy bodies is that although it is a progressive condition, we can actually make very substantial improvements for patients with treatment. The best treatment that we currently have available is the range of drugs that was originally developed for Alzheimer's disease, such as donepezil, rivastigmine or galantamine. These drugs, which can have helpful effects in Alzheimer's disease can sometimes have quite dramatic effects in dementia with Lewy bodies. So, for example, a patient may lose their hallucinations, may be transformed from being drowsy, apathetic, confused, to being alert and relatively lucid, and may also have just a global improvement in the quality of life. And we know from trials that these effects can last 1, 2, or even more years. The medical treatment of dementia with Lewy bodies is complicated because it usually contains 2 or 3 elements at least. If the person has significant Parkinsonism, they may require treatment for that with drugs like levodopa. But of course these drugs have to be titrated carefully because they can produce side effects such as increased confusion. That type of treatment would often be given by a movement disorder specialist. Another type of drug treatment that a person with dementia with Lewy bodies might get would be a cholinesterase inhibitor as developed originally for the treatment of Alzheimer's disease. These drugs can be very effective for the mental symptoms and reducing or even banishing the visual hallucinations. These drugs are often given by a specialist in old age psychiatry. Treatment might be given for the REM sleep behaviour disorder, which sometimes responds extremely well to a low dose of a sedative drug called clonazepam given at bedtime. And of course, most of these patients, because they're elderly, also have other physical conditions for which they're receiving additional medications, and one has to be very careful that the medications are compatible with one another. Dementia with Lewy bodies affects an older population, as do most dementing disorders. So most patients that I see would be over 65, and in fact the majority would be over 80. But that doesn't mean to say that there aren't occasional people who develop this as early as their 40s or 50s. On average, people live for about 8 years following a diagnosis of dementia with Lewy bodies, but this can range from as little as 2 to as much as 20 or even more. Dementia with Lewy bodies is part of a family of conditions which are related to an underlying process called Lewy body disease. If you develop Lewy body disease when you're in your 50s and 60s, the chances are you'll present with Parkinson's disease. In other words, it'll be predominantly a movement disorder. If you develop Lewy body disease in your 70s and 80s, the disease affects a different part of your brain and it will present as dementia with Lewy bodies. So the type of symptoms that you have depend upon the age at which you're affected. There's currently a very active interest in researching dementia with Lewy bodies, but that hasn't always been the case. If you look back even 15 or 20 years ago, there was virtually nothing published in this field. If you look in the last 2 or 3 years, there are several hundred papers a year being published, which testifies to the number of people who are now becoming involved in it. Most of the research in dementia with Lewy bodies has been about describing the condition, describing the clinical features and the way that patients present. And that's led us to a situation where we now have standard diagnostic criteria which can be used by clinicians or researchers across the whole of the world, and indeed they are. Because we have standard criteria for diagnosing patients, we're in the position that we can do clinical trials, and the clinical trials can be really quite exact about the kind of patients that we're including. There's also a wealth of biologically based research trying to understand the nature of the Lewy body. What is a Lewy body? What do Lewy bodies do in the brain? We used to think that Lewy bodies were toxic to nerve cells, that they were abnormal proteins which killed nerve cells off. In the last 2 or 3 years, we've begun to understand that Lewy bodies are probably an attempt by nerve cells in the brain to protect themselves. They're a dustbin, if you like, in which abnormal proteins get put as a place of safety. The research efforts therefore moved to trying to learn which are the toxic, the bad proteins that are damaging nerve cells. And we're making significant progress. Even within the last year or two, researchers have identified changes at the very periphery of nerve cells, very small aggregates, small collections of an abnormal protein called alpha-synuclein. And this is a potential treatment target. If we can understand how these small aggregates of abnormal proteins occur, then we're in a position, of course, to stop it happening and probably to reverse the disease process. The research programme in dementia with Lewy bodies has been operating in Newcastle since the late 1980s. Newcastle was one of the first places where dementia with Lewy bodies was recognised as a common form of dementia in older people. And since then, we've collected cohorts, groups of patients with the condition, and we've followed them through their lifetime, doing a lot of biological tests, brain imaging, memory tests, and things of that kind. And after the person's died, we've obtained consent for post-mortem examination of the brain. So we've been able to correlate brain changes with the symptoms the patients had during their life. And it's that kind of research, which is now called clinical translational research, which leads to developments in treatment. One strand of our research in Newcastle has been to pursue the risk factors for developing dementia with Lewy bodies, particularly the genetic risk factors. Although it's not an inherited disorder, we do know that some genes confer increased risk. We have a PhD student working on this genetic risk program currently, who's funded by the Lewy Bodies Society, and Marzena's particular interest is looking at a gene called the glucocerebrosidase gene, which we know is associated with DLB and related disorders. Although genetically determined cases of dementia with Lewy bodies, or indeed any disease, are rare, they often give you information about mechanisms by which the disorder can occur. So if we can unravel and understand the mechanism from an abnormal, a rare case, we might be able to generalise that treatment to treat every case. If you ask people with dementia what aspects of the condition they want researching, they nearly always say that they would like us to understand the cause in order to generate a cure. And that is the kind of research programme which we have developed in Newcastle and which we intend to sustain. But that does require a commitment from patients and the families on one side, who are willing to come up and have exhaustive testing and investigation, and also the ability to fund the research for many years until the person dies, and we're able then to examine brain tissue, because that correlation between brain and clinical symptoms is actually the key to unlocking these diseases. We really have only understood the importance of dementia with Lewy bodies for less than 20 years, and already we've moved to the point that we are able to diagnose it in a substantial number of cases with a high degree of accuracy. We are beginning to understand the mechanisms that cause the disease, which will allow us to generate new treatments. So we've moved very quickly, compared with a lot of other diseases, from first recognition to being on the point of reasonable understanding and a reasonable prospect of cure and significant treatment. What we need to do next is to establish some large-scale clinical trials and try out the new treatments. Setting up large clinical trials in dementia with Lewy bodies is not an easy challenge, because there's still a relatively low awareness of this diagnosis in the community, the general community and still the medical community. And there's still a relatively small pool of skills of people who can carry out this kind of research. A priority for the Lewy Body Society and for all organisations interested in Lewy body disease is to increase awareness of the condition and to increase the skill level in diagnosing and doing clinical studies. The Lewy Bodies Society is the only charity dedicated to supporting dementia with Lewy bodies in the UK currently. It's been instrumental in developing information which is available for carers and also for professionals caring for people with dementia. It also has started raising funds to support research students like Marzena, the PhD student who works in our laboratories in Newcastle. I find the information that the Lewy Bodies Society offers to patients and carers through the website to be a particularly useful thing in the clinic, so that after we've finished the diagnosis and the discussion about the diagnosis, I will always give them the website address and recommend that they go there to look for additional information, which they can do at their leisure, and then they can contact the Society with additional questions or requests for information.
For more information, please visit our website www.lewybody.org. Thanks.